and the organizing committee for giving me this opportunity to talk to you today about utilization of pharmacogenomics and optimizing immunosuppression. I have nothing to disclose in relation to this presentation. Just as an outline for what I would like to talk about today, I would like to talk about the unmet need for personalized immunosuppression, utilizing pharmacogenomics as a tool for precision medicine and solid organ transplantation, and recent findings and insights of impact on tacrolimus metabolism on clinical outcomes. This paper was published in 2008, and it shows that having adequate dose of calcineurin inhibitor is essential better graft survival. We can see here that whether it's a cyclosporin or tacrolimus, if we compare the reduction, calcineurin inhibitor minimization, or complete withdrawal was associated with statistically significant lower percent graft survival compared to the standard dose. So the take-home message, the more calcineurin inhibitor, the better graft survival. The problem with this is that there are so many side effects and complications of a calcineurin inhibitor. This is just one example of them, is the risk of developing diabetes mellitus. So how do we balance these two competing interests of keeping the graft alive, but also keeping the patient alive and without so many complications? So pharmacogenomics seems to offer a promise to help us in this optimization and individualization. So if we talk about CYP3A5, which is one of the genetic variants that affect the metabolism of tacrolimus, there are multiple alleles described thus far. There is star allele 1 that is associated with normal function. And as far as we know, this is the only one associated with function of this enzyme. There are star allele 3, which is common in Caucasians. Star alleles 6 and 7, common in African Americans, are known to have no function. And there are a number of other alleles that have been described, but they are not being described in enough numbers to characterize their phenotype in terms of metabolizer state. And just to show you where this works, it works on the GI, affecting the absorption of tacrolimus. Then it works on the liver, affecting metabolism. And whatever makes it to the bloodstream, that's really the effective drug level that affects T cells. Of course, there is the CYP3A5 has nothing to do with the pharmacodynamics. It doesn't affect how the tacrolimus interacts with the receptors on the T cells. This is one of the earliest studies that got me really interested in this field of pharmacogenomics. And it is a Belgium study that looked at different genotypes and however some adjustments in the blood level and the dose could lead to equalization, if you may, in blood levels. So they took the low metabolizers that have the 2 copies of the functional allele, and they give them the lowest doses. One is 0.20 milligram per kg per day, and 1.25. And they took those who have at least 1 copy of the functional allele, and those included 2 subgroups, the intermediate metabolizers who have 1 copy of the functional allele and 1 copy of the non-functional allele, and give them 0.3 mg per kg per day. And they, group 4, that were homozygous for the functional allele, and they give them 0.35. And you can see that this group actually almost have double the dose of the lowest dose in the low metabolizer or non-metabolizer group. But to our surprise, regardless of the genotype, regardless of the dose adjustments, less than 60% of patients in all groups actually were in the therapeutic range. Where were the rest of the patients? Well, not surprisingly, the high metabolizers, even though being on higher dose, still remained a significant proportion of them in the infratherapeutic range. And those who were in low metabolizers or non-metabolizers who received lower dose remained still in the supra-therapeutic range. So really the notion that in the sentiment in most of the literature is that the high metabolizers are the disadvantaged group because they don't have enough blood level and they get more rejection, and which really dampen the enthusiasm for using pharmacogenomics because at least in Caucasian, these are less than 10%. So it doesn't seem to affect many patients to justify testing everyone for pharmacogenomics. So let's see how this really works. So in this study on African Americans, it was shown that actually the high metabolizers actually had less proportion without rejection compared to the low metabolizers, which is not surprising. This is a randomized clinical trial of age and genotype guided tacrolimus dosing after pediatric solid organ transplant. And it really showed that using genotype guided dosing actually achieved faster therapeutic range, but even more importantly, they achieved significantly faster stable therapeutic range because you don't want them just achieving it and keep coming in and out of it. You want stable therapeutic range. And yes, it does not, this polymorphism or genetic testing does not explain many other factors such as pharmacodynamics or even other non-pharmacologic factors such as non-compliance, but taking together in a multivariable model that took all things that affect the blood level, it actually, CYP3A5 was actually had the highest statistical association 10 to the power of minus 29, and it was estimated to explain at least 36% of the variability between patients, intra-patient variability. And that's why it came in the CPEC, which is the Clinical Pharmacogenomics Implementation Consortium guidelines, that were in the extensive metabolizers and in the intermediate metabolizers with a strong level of recommendation that they need 1.5 to 2 times the recommended dose to achieve the target therapeutic range. Is this cost effective? This is a study from the EU, and actually it showed that there is a clear cost benefit from using pharmacogenomics testing because it reduced the total cost of care by about 4,000 euros per patient. It led to 6% less hospitalization days and the lower risk of adverse drug reaction, which all culminated into 0.9 quality adjusted life years. They incorporating pharmacogenomics in addition to other pharmacokinetic factors, like and also other biologic factors such as age and body surface area, resulted actually in avoiding tacrolimus underexposure and overexposure. And here we can see starting from day 3 and carrying on until day 10, the majority of patients actually within the therapeutic range, and to compare this to what we have now with only less than 60% in the therapeutic range using the standard dosing. This is a study we presented in the American Transplant Congress last year in 2024, and we showed that when we test for CYP3A5 prospectively and adjust the dose, we significantly lower the rejection, the clinically significant rejection, which is more than 2R in heart transplant recipient. And here there is a group of patients we tested retrospectively, but of course we didn't have a chance to act on the results. And here is a group of patients that were testing prospectively because we have been testing prospectively at Baylor University Medical Center since 2018. And we can see here that there was no statistically significant difference in baseline characteristics or even in the genotype distribution. The only statistically significant difference actually was induction. And if anything, the prospective group, the majority of them didn't receive induction. So there is no reason to believe that the results are skewed to favor the prospective group. And here we can see of the 51 patients who were typed retrospectively, meaning the results of pharmacogenomics were not available at initial dosing, 11 of them, which is 20%, had clinically significant rejection compared only to one of the 100 patients that had prospective results, which was highly statistically significant. We also presented this in the TTS Congress in Istanbul last year in 2024. And since then, actually, it got accepted in clinical transplantation. And we showed that patients who are low metabolizers actually had statistically significant higher cumulative mortality. And the difference wasn't from circulatory death or malignancy, but was mainly due to infection. And we classified patients based on the CDR, which is the ratio between the blood level to the dose. And we found that a combinatory analysis of impact of low less than 1.05 and normal tacrolimus trough level dose at post-transplant at years 1 and 2, death censored graft survival during years 3 and 4 post-transplant. What we found is that if they started with normal CDR and had normal CDR at year 2, they actually had the best death censored graft survival at year 4. Those who had low CDR at year 1 and year 2 had the worst outcome at year 4. And what was really, really intriguing the study is that those who were low initially, but they were normalized later, they had somewhat better outcomes at year 4. In our study, we showed that low CDR at year 1 was a strong predictor of graft loss and mortality. And actually, this wasn't a small proportion of the study. It was 25% of kidney transplant recipients in our cohort of 21,000 patients that were reported to the CTS, the Collaborative Transplant Study database in Heidelberg. Low CDR predicted poor outcomes, even in patients with therapeutic tacrolimus level. So really, there was an added value of monitoring CDR over just monitoring the trough level. And the 35% of patients with low 1-year CDR achieved normal CDR by year 2, which supports monitoring for CDR as a clinical intervention tool. And the low CDR specifically increased infection-related mortality with hazard ratio of 1.63. And in this study, we actually reported the highest association between CYP3A5 star allele 1 and low CDR, which is higher metabolizers. In summary, there is an unmet need for personalized immunosuppression, and PGX testing yields clinically actionable results that are conducive to practice of precision medicine and improving clinical outcomes. And PGX2 testing is cost effective. At the end, I would like to welcome all of you next month to our conference in Egypt, Donate Life Egypt, where many of you hopefully will be joining us and many others. So I'll stop here and take questions. Thank you very much.